Now we invite Dr. Soumyava Basu, who has done pioneering work in tuberculosis, particularly tubercular uveitis and tubercular retinal vasculitis. We are very proud of him, and I like to call upon and to talk on retinal vasculitis stepwise investigations and management. This will be very practical tips.
Thank you, sir. Thanks for allowing me to speak on this forum. So, why is retinal vasculitis so important? It's one of the commonest forms of uveitis. Up to 10% of all uveitis that we see in our clinics are primary retinal vasculitis, and a substantial number of other uveitis entities also have a secondary retinal vasculitis. So, it's a very common entity. And it is quite different from systemic vasculitis, because unlike systemic vasculitis, if you speak to our rheumatology colleagues, they'll tell you that they need a histopathological diagnosis to call it vasculitis. On the other hand, we do not have that, but we can directly see the disease, which our rheumatology or other colleagues in other specialties can't do. Directly see the retinal vasculitis in the patient, and that's a huge advantage. Now, here are 2 points that I want to emphasize very much. One is that retinal vasculitis is very frequently associated with systemic infections or systemic disease. And this is different from the fact that it is rarely associated with systemic vasculitis. So all the things that rheumatologists deal with, the ANCA-associated vasculitis, etc., those do not cause retinal vasculitis. If you want to look at the literature, you should look at Professor Rosenbaum's studies to verify this fact. So testing for ANCA, for ANA in patients who do not have any systemic disease of ANCA or ANA is a very futile exercise. Now, how do we go about looking at these patients? First, find out what type of vessel is involved. Is it the arteriole or the veins or both? What are the sizes of the vessels? Mainly the capillaries or the medium or larger vessels? What are the morphology of the infiltrates? And I'll come to it in a while. And once you have characterized the vasculitis, see what are the other ocular signs and what are the other systemic signs in the patient. So, when it comes to the type of vessels, most retinal vasculitis that you will be seeing in your clinic will be involving the veins. They are periphlebitis, and the 2 conditions that are commonly associated with periphlebitis are TB and sarcoid, and these are probably the most common causes of vasculitis that you may be able to pick up. Behçet's can also cause primary retinal periphlebitis. Arteriolar involvement is mainly seen in the infectious retinitis, for example, viral retinitis or toxoplasma retinitis. These are secondary arterial involvements. Then some of you might be familiar with this condition called as IRWAN, where you see retinal arteriolar macroaneurysms. And in those rare cases where SLE or polyarteritis nodosa cause retinal vasculitis, you may see arteriolar involvement. Similarly, the ANCA-associated vasculitis, when those very rare cases where the retina is involved, will cause a mixed arteriolar and venous involvement. Behçet's can also cause that. Now, what are the different morphologies? See, these whatever I'm discussing so far, they do not need any kind of lab test. This is just what you're seeing in the patient. So what are the different morphologies you can get depending on the severity of the inflammation? You can get skip vasculitis, or you can get an confluent area of vasculitis. Then there are other patterns like frosted branch angiitis. You just saw some pictures, Chiariles vasculitis, occlusive vasculopathy, and IRWAN, and let's go through some of these. So you can see this is a confluent vasculitis which shows the severity of the inflammation in this patient, whereas in the infranasal quadrant you see this is a skip vasculitis, a small area of inflammation. This is a classic picture of frosted branch angiitis. This is Chiariles vasculitis, which you see here. I've picked up from this small part, and you can see these are intraluminal opacifications, which you can see here. They do not represent active inflammation. Instead, they come up when the retinitis, which could be due to toxo or TB or CMV, when that is resolving, that is the stage when you see this kind of Chiariles vasculitis. Occlusive vasculopathy. Now, as you can make out from the name, this is not a vasculitis, so you do not see any perivascular exudation, but there is a vasculopathy, and one example is Takayasu's arthritis, where there is no perivascular exudation, but huge retinal hypoperfusion. You can see almost the entire retina is without capillaries. Another cause of occlusive vasculopathy, in this case Aplar syndrome in SLE, and you may also see those rare cases of Suzak syndrome causing occlusive vasculopathy. So no exudation but huge hypoperfusion. You can see this in the FFA here. Now this is one condition that you come across very rarely, idiopathic retinal vasculitis, aneurysms and neuroretinitis, short IR1, more common in females. But apart from the macroaneurysms, which I'll just show you, what is very characteristic is this huge macular star or exudation, and this is the most common cause of loss of vision and very refractile to treatment in these patients, and this is what we deal with in the clinics. And also there is this, these might be healed, as can be seen here. If you see lesions like this on a blood vessel along with retinal vasculitis in a TB endemic country like India, you're almost sure that you're dealing with tuberculosis, irrespective of what the test results show you. Then occlusive vasculitis, TB more likely than sarcoid, and you cannot get away from there. These are features of sarcoid that you should look for in patient of retinal vasculitis. In the inferior and nasal fundus, you typically see these discrete hypopigmented spots, and in the anterior segment you may find the granulomatous anterior-uveitis with peripheral anterior synechiae. Behçet's disease, you see this either a capillary involvement with a retinitis seen here, or a typical retinal periphlebitis as seen in the right eye of this patient. When you do the angiogram, you just heard about how you see the ferning of these vessels. An important point to stress here is that Behçet's is not diagnosed by testing for HLA-B51, because as you just heard in the previous talk, up to 40% of Behçet's patients can be negative for B51, and up to 30% of the normal population can be positive for B51. So B51 is not a diagnostic test for Behçet. Instead, the diagnostic criteria include the ocular features and the systemic features, especially the ulceration of the oral and the genital regions. So this is seen here in this picture. There's no mention of B51 in these criteria. These are secondary vasculitis to infectious retinitis. This is toxoplasma seen here. You can see this one happening. You just treat the toxoplasma, it goes away completely. This is secondary to acute retinal necrosis. You see the tongue-shaped extension of the acute retinal necrosis here. So how do you combine all of these to reach an etiological diagnosis? We start with cases or sometimes pars plana vitrectomy to deal with the complications. This is one case that required just anti-TB therapy, and you can see the picture after 4 months of anti-TB therapy, which shows that this is not any kind of hypersensitivity reaction. This is a pure infection of the retina that causes the TB retinal vasculitis. So to summarize, the retinal vasculitis is caused both by infections and systemic diseases, but rarely by systemic vasculitis. You look at the type of vessel, size, morphology, associated ocular and systemic signs, characterize the morphological appearances and the associated ocular signs to reach the diagnosis and treat the inflammation and the complications. Thank you very much for your attention.